My patient, Mrs. X, 56-year-old lady, who is homemaker from Ashta and has educated till higher secondary from a socioeconomic class of class 2 according to modified Biji Prasad classification, married since 28 years through a non-consanguineous marriage. She has been examined on 9th of June 2020. She came to me with a complaint of a lump in the left breast since 4 months and ulcer of the skin over the lump of the same breast 1 month ago. There are no other complaints from the right breast or no swelling in the right axilla. History of presenting illness. The lump in the left breast for 4 months, felt a lump in upper outer quadrant of the left breast, which was insidious in onset and rapidly progressive in size, initially from 3 by 1 centimeters to 6 by 6 centimeters now, and the lump is painless throughout. No lump was felt in the past. Then she developed a painless ulcer on the overlying skin, which was initially about 1 by 1 centimeters and now 3 by 2 centimeters in size, that does not involve the nipple areola complex. There is no bleeding or discharge through the ulcer. There is no history of nipple retraction, discharge, or any complaints from right breast or any swelling in the bilateral axillae. There is no history of trauma to the breast, no history suggestive of distant metastasis such as backache, dyspnea, hemoptysis, headache, seizures. There is no history of any constitutional symptoms, loss of appetite, or significant unintentional weight loss. No history of taking OCPs or hormone replacement therapy or irradiation to breast. She is non-diabetic and non-hypertensive, denies any chronic illness such as tuberculosis. She has not undergone any medical or surgical intervention and has no any allergy or has no history of any drug intake. She is a non-vegetarian by diet, has a normal bladder, bowel, and sleep pattern, has no history of any addictions. Her menarche started at age of 15 with regular cycles of 4 to 5 days duration, and she attained the menopause 6 years back. She's a gravida 2 para 2 L2 where 2 children both were full term delivered by normal vaginal delivery. The younger boy of 21 years and elder boy of 25 years both are healthy. Both were breastfed up to 6 months. There is no history of abortions. There is no history of breast cancer or related deaths in the family, and there is no history of BRCA-related malignancies such as pancreatic, colorectal, prostate, or ovarian in the family. Summary: a 56-year-old lady complaining of lump in the left breast since 4 months and ulcer on the overlying skin since 1 month. The lump was insidious on onset and progressively increasing in size from 2 by 1 to 6 by 6 centimeter, which was painless.
Good. Good history. It was a very detailed history. Wonderful. So shall we go back to the first slide?
I think we have lost him.
Yeah. No, he's there. Kaustubh is there.
No, probably there's some problem with his connection.
Yeah.
If somebody has the PPT, I think we can project and just ask him to.
Yeah, like I had sent you one, but some after that I have made him some corrections in the PPT. So only final PPT only he has the PPT. That's why we'll wait for 1 minute. Yeah, he's
Hello.
there. Yeah, Kaustubh, are you there?
Yeah, sorry, sir. There are heavy rains over here, so the line
so
was
you
off.
want us to project the PPT, or is that okay? You'll share?
Yes, I'll share. I'll share.
Okay. So
I'll
we'll
share,
go
sir. I'll have.
Okay.
1 sec.
Kaustubh, meanwhile, please send the latest PPTs to Nishanth sir also once. Okay. If anything happens, he will try to share.
Okay,
Is
sir.
that
Okay.
okay, Dr. Nishanth?
Yes.
Yeah, sure.
So
Yes, sir.
good history. Okay, there is a very detailed history. Good, Kaustubh. So shall we go back to the first slide?
Yes, sir.
So can you tell me, Kaustubh, what is the significance of socioeconomic history in an elderly lady? Can you give some examples of different conditions in different socioeconomic classes?
Sir, lower socioeconomic class, where their habits of living and hygiene are quite disturbed and not much well, there is a risk of inflammatory diseases more because of infections like mastitis.
Inflammation or infection?
Infectious diseases.
Okay. Now give me some specific example, 2, 3 very common one or important ones. In an elderly lady, I'm asking you, or any lady for that matter.
Okay. Lower
No, okay. Tell
socioeconomic.
me carcinoma of breast. Okay. So this
Yeah.
is more common in which socioeconomic group?
Sir, mostly in the higher ones.
Okay. So similarly in lower socioeconomic group, any examples you know? Maybe in
Uh,
breast only, or
no,
any
sir.
other
Class
cancers?
wise, I don't know.
Like tuberculosis is most common in.
Lower classes.
Yes. So cervical cancer,
Lower class, sir.
then in lower socioeconomic status. Okay, like that.
Yeah. Okay.
So married, non-consanguineous, very good. Okay, so age and all we have discussed all this. So we'll go to next slide.
Okay.
Okay, lump and ulcer she complains of, and don't write this. No complaint. Nishan, is it required to
No,
write the in
no.
chief complaints? Don't write all this.
Yes,
Okay,
chief
no
complaint is only
complaints
the
of.
chief
That's
complaint.
again in a HOPI you can mention. Okay,
Yeah.
so
Okay, sir.
no need
Okay.
to write that. So only complaint is lump in the left breast and ulcer of the skin over the lump in 1 month. Okay, so
Okay.
what do you think? A lump and ulcer. What are the possibilities?
Sir, two basic possibilities. Looking at her age and old age, one possibility is a malignant ulcer, malignant lesion.
Okay,
And the second possibility is a phyllodes tumor, but this is not going along with her age.
okay. So what age group? Phyllodes is common.
Or 20, 20, 30s.
Okay. So what are other possible complaints in case of if say it's a CA carcinoma? What are the other possibilities? Or
Sir,
in general, what are the chief complaints in breast case?
sir, nipple discharge,
Okay.
then nipple retraction,
Mm-hmm.
fullness in breast.
Mm-hmm. Can you
Where
give me
does
some example for painful conditions of breast where they present with pain?
Painful conditions.
need not be an elderly female Kaustubh.
Yeah, any. Okay, in general we are discussing because
Okay,
CA we
sir.
have discussed enough. So we'll today
Okay.
we'll take this opportunity to discuss. Is it okay, Dr. Nishanth?
Yeah, please. I have also prepared lots of questions which are not related to CA breast.
Yeah, because CA breast
Uh,
already we had 2-3 sessions. So we'll in detail we have got a good candidate as well. So we'll take the advantage of some painful
uh,
conditions of breast. Okay, like I'll
Sir,
give you
it
one
could be
like
acute, it could be mastitis,
very
and
good.
even it could be cyclical mastalgia associated with
Okay,
Andy.
okay. Then can be
Um,
abscess or even a
yeah,
fibroadenosis. You told cyclical mastalgia is called fibroadenosis. Then
yes,
it can be even another thing we should remember is musculoskeletal pain also. Okay, that's also common
yes.
in ladies. Okay, what is Teat syndrome? You know what is Teat syndrome?
Teach syndrome.
Teats disease or Teat syndrome? You know anyone?
Uh, teach syndrome, I have heard somewhere. Sir, it's related to costochondritis, I think.
Okay. Oh yeah. Costochondritis of the second rib. Okay. Okay.
Yeah,
So it's also
yeah.
comes like a breast pain only. Hmm?
Okay,
So
okay.
you know about this nipple discharges, various nipple discharges and all. You know in which color or like what's the like indication of carcinoma, everything you know? Do you know?
Yes, sir. Yes.
Okay. So retraction of nipple, where all you get retraction of nipple? There are different conditions of retraction nipple.
Or
Can you tell me some
circumferential
examples?
retraction we get in carcinoma of breast, and slit-like
Mm-hmm.
retraction we get in ductal ectasias.
Mm-hmm.
Okay. Kaustubh, one question related to nipple retraction.
Yeah.
Assume that you are seeing a fullness in the upper outer quadrant, and you see a nipple retraction. In one patient, it is towards the upper outer quadrant. In the other patient, it is away from the upper outer quadrant.
Yeah.
So what are the two possibilities? And you need to tell me why.
You understood the question, no? What is tell?
Yes, sir.
Yeah.
Okay. I will make it much more simpler. There is a lump in the upper outer quadrant. Okay. You have two patients. Both the patients have a lump in the upper outer quadrant. In one patient, the nipple retraction is towards the upper outer quadrant. In the other patient, it is pushed away from the nipple outer quadrant. That means probably the retraction is towards the inner and lower quadrant.
Yeah.
Okay. Nipple retraction in the same direction.
Which one is suggestive of malignancy and which one is suggestive of?
Sir, towards the lump is suggestive of malignancy.
Okay.
So
Why?
tell me first why there is a nipple retraction. Tell me, then you will understand.
Sir, basically nipple retraction is because of fibrosis of the lactiferous duct, basically.
Is there something else there which runs all the way from the pectoralis fascia to the level of the nipple?
Ligament of Cooper.
Correct. So there's infiltration of ligament of Cooper, which kind of has a tugging effect on the nipple. Okay. So if it's a CA breast, it invariably infiltrates these ligaments of Cooper and they cause retraction towards the lesion. If it's a benign disease, invariably the nipple and the areola is pushed away.
Okay, yes.
Okay. So the second one is more common in a benign breast disease.
Okay.
Go to the next slide.
While we are here, because a lot of people have commented on Cooper, actually I did some homework. What are all the different structures in the body or different conditions which are named after Cooper? Okay. Where all can you have Cooper's ligament?
Yeah, Cooper's ligamental. There are two ligament. Yeah.
Yeah, there are two Cooper's ligament.
Yeah, tell me. You answer, Kakade. You directly answer. You can also answer.
Okay. Sir, Cooper's ligament in the inguinal region and one is in the ligament of Cooper in the
Excellent.
breast.
Suspensor ligament of Cooper. Very good.
Okay. What is Cooper's hernia?
Cooper's hernia.
I'll give you the answer. It's a retroperitoneal hernia. Okay. And then there is something called Cooper's fascia, which overlies the testis. And there is Cooper's neuralgia. There are two types of neuralgia. One is neuralgia of the testis. The other one is neuralgia of the breast. Both of them are called as Cooper's neuralgia. And apart from that, you have something called as a Cooper's disease, which is nothing but benign breast cyst, is also called as Cooper's disease.
Okay.
What is that in fallopian tube? Bhavi has told something in anything. I don't know. Something in
I'm
fallopian
seeing
tube.
it for the first time.
Okay. Anyway, so shall we move on to HOPI?
Yeah, please.
Okay. The fineless. No, first slide. Before this, lump. Okay. For 4 months, duration very good. Felt a lump. Okay. Lump is spineless. No lump was felt in the past. What is that? No lump was felt in the past.
Sir, that was to rule out this Fallot's tumor because previously present lump may grow in size, infiltrate into the skin and cause the ulcer. That's why.
No, that will be there since 4 months only. No, if it's a phylloids also, it will be.
Yes, yes.
Yeah. So what other lump you you want to know or want to ask? Anything specifically? Why did you ask?
So for phyllodes only.
Phylloids. So it's not required, right?
Yeah.
Both presentation are almost similar. Okay. It's in fact in phylloids they will have a earlier presentation. Okay.
Yes,
so not required. Next slide. Ulcer. Okay. Now pileless ulcer. Okay. does not involve the nipple areolar complex. Why did you write a size that does not involve the nipple areolar complex? Why did you write that? Specifically, you mentioned ulcer doesn't involve the nipple areolar complex. Why?
What do you call it if it is if it involves the
Involving-
nipple areolar complex?
Paget's disease.
Correct.
Someone asked what the difference between a wound and an ulcer. Okay, so any discontinuity in the lining epithelium or lining epithelium, that's called wound. Okay, along with the necrosis of the tissue, that's called ulcer. Okay, discontinuity. And no history of nipple retraction, no history of nipple discharge, no complaint in the, no history of swelling in the axilla. Okay. Fine.
One question, Kaustubh. What are the types of nipple discharge?
Sir, bloody discharge.
Which condition do you see them?
Mostly in our ductal papilloma, we get bloody discharge.
Not mostly. The most common is ductal papilloma.
Ductal papilloma.
And that also if it's from a single duct.
Yes.
Okay. Yeah. Next.
Then milky discharge. Then we have serous and mucoid discharge.
No,
then
you have to tell me milky discharge in which condition?
During lactation.
Galactoria.
Galactoria.
Okay. Yeah. And then serous discharge in?
Serous discharge in ductictasia.
Correct. Fibrocystic disease and
Fibrocystic
puberty.
disease of breast. Yeah.
Greenish discharge?
Greenish discharge again, sir, fibrocystic disease and ductal ectasia.
Yeah, it's more characteristic of ductal ectasia. You never spoke about carcinoma.
Sir, carcinoma.
What's the characteristic of discharge in carcinoma?
Carcinoma is bloody.
Yes.
Okay.
It's
And
bloody.
more, yeah. Unilateral.
Bloody. And more than one duct is involved usually. If it's a single duct bloody discharge, the most common cause is papilloma.
Okay.
Okay. So now go to the next slide. Yeah. So no history of trauma. Why is that trauma here? What do you want to rule out?
Oh, sir, trauma, like we can rule out any traumatic breast abscess, or we can look for like blood collection,
More commonly
hematoma.
After trauma, what happens?
Hematoma, fat necrosis.
Okay, good. So these are traumatic fat necrosis syndrome very closely resembles. Okay, so we have to rule out that.
Yeah.
Okay, that's it.
I'll just stop you at that one. Just one point, Kishan. For this patient, you have no business asking for trauma to the breast because you have already said the patient has an ulcer. Okay.
Yes.
Can a trauma, which is even if it's happened 4 months back and the patient has a swelling, I can understand it might be an organized hematoma, fat necrosis. But for that to progress to an ulcer which overlies the lump, highly unlikely. You will get caught if the examiner really wants to put you into trouble. He can put you into trouble with this question.
Okay.
Okay. So for this patient, okay, I repeat, for this patient who has an ulcer, kindly avoid history of trauma for this patient.
Okay, sir.
Okay. So and see, he is so disorganized. Okay. Suddenly, then why did you go to suggestive of distant metastasis? You are still not proved that it's a malignancy. So why did you directly go to features of metastasis? First, you rule out all the benign other conditions. Okay, traumatic fat necrosis. Okay, hematoma you rule out. Then comes any other features of malignancy is there. Then if there are, then step by step. Okay, after malignancy, then there will be metastasis, right?
Yes.
You're getting my point.
Yes, sir.
Whatever you do it in a organized way. Okay. So next you would ask, no any constitutional symptoms. What constitutional symptoms? Constitutional symptoms of what? What you're asking?
Sir, like fever, body ache, and all those things to rule out any infective cause.
Okay.
No. Kaustubh, when you say constitutional symptoms, I think you are talking about constitutional symptoms related to malignancy.
Yeah.
Okay, your fever and all is more in terms of lymphoma. For here, it will invariably just be loss of appetite, loss of weight. At least for this, for cases in breast carcinoma. Don't say fever and all.
Okay, history of fever is important. Why? Tell me. In case of breast disease, what is the relevance of history of fever?
Sir, breast abscess.
Okay, even a chronic breast abscess maybe. Okay, may mimic like carcinoma, so it may be important. But yeah, what I suggest you is go in a orderly manner. Okay, don't write haphazardly. Okay, first prove that it's a rule out all the benign conditions like said fever or maybe trauma, all those things. After that, then prove that there are some constitutional features or like it's malignancy. Then prove that there are any metastatic features or not. Clear?
Okay, sir.
Then go for what is the causative factors like you mentioned, like what is history of OCP, HRT, irradiation? Tell me the significances of each. Fast, quickly. We should go very quickly.
Okay, sir. OCP and hormone replacement therapy both containing estrogen. So high estrogen exposure may lead to will act as a risk factor for malignancy. And irradiation, again, low dose radiations may cause proliferation of ductal cells leading to ductal carcinoma.
Okay,
So
yeah, just one thing. You have mentioned saying no symptoms suggestive of distant metastasis such as backache. How does the patient end up having backache? Or why have you asked for backache?
Sir, because one of the most common site of distant metastasis via Batson's plexus is vertebrae, and
Which
that's
vertebrae?
why lumbar vertebrae,
Okay.
upper lumbar vertebrae, and
Why
that's
is
why the
it only
patient will
lumbar
present.
vertebrae? Why aren't the other vertebrae involved?
Why lumbar?
The first part of the answer was correct. So basically what happens, these cancerous tumor cells, they travel through the posterior intercostal veins, which then communicate with the Batson's plexus. Okay. Batson's plexus is a valveless plexus. From there, it reaches your spinal canal. In your spinal canal, because of gravity, they tend to go down. Although the breast is at the level of the thoracic vertebra, they tend to travel downwards because of gravity. And at the level of lumbar vertebra, the canal is narrow. So there is maximum resistance there. So the tumor cells tend to stay there for a longer time before they go down towards the sacrum. Because they're there for a longer time, the first vertebra to be involved is the lumbar vertebra.
Okay.
Okay. And next, you said dyspnea. So why have you asked for dyspnea?
Sir, lung metastasis, dyspnea and hemoptysis.
Lung metastasis?
Involvement of lung, distant
Lung,
metastasis to lung and
repeating.
also pleura.
Pleura is more common. So dyspnea and difficulty in breathing or chest pain, they'll have pleuritic type of chest pain. That is more common than hemoptysis. Okay. Which is more common, lymphatic spread or hematogenous spread?
Lymphatic spread, sir.
Lymphatic spread, correct. So if a patient from breast carcinoma should have lung metastasis, it has to go through the veins, then to the heart. From the heart, it has to be pumped to the lung. Okay.
Yes.
So it takes a longer time. So because lymphatic spread is more common, it initially involves the posterior intercostal lymph nodes, and then it spreads pleura. Okay, so it's usually lymphatic spread. Then I think you missed out one more important history. You didn't ask for history of abdominal distension here.
Yes, sir. No.
Okay. Why do you ask for abdominal distension?
Sir,
Okay. Did you think about asking for jaundice?
yes, sir. Liver involvement, liver metastasis could cause that, and then if there is a massive metastasis, that may cause hepatosplenomegaly and ascites, leading to distension of abdomen.
Okay. Now again, liver metastasis is more common lymphatic or hematogenous?
Hematogenous, sir.
Are you sure? It's lymphatic. Okay. So what happens is you have your retrorectal, the lymphatics, from the breast and the skin. they run along the external oblique because it is just there, just beneath the level of the breast. At the inferior level, you have the external oblique. Then it runs along the retrorectus, that is along the rectus sheath. Then the subdiaphragmatic. Then it runs along the falciform ligament, and then it reaches the liver. So more commonly, you have lymphatic or subcapsular deposits on the liver. Okay. Again, just think about it. If it has to reach via hematogenous route to the liver, it has to go via the hepatic artery. Again, it has to go to the heart, from the heart to the aorta. Then it has to go to the descending aorta, and then through the hepatic artery, and then come to the liver. And we've already discussed lymphatic is more common than hematogenous.
What's the lymphatic supply of breast? Tell me the lymphatic supply.
Sir, there are 75% is supplied by axillary group and 20 to
From where
25%
what
is
drains? There are two types: superficial lymphatics, deep lymphatics.
deep lymphatics. Yes.
Okay.
So basically, deep lymphatics are axillary group of lymph nodes and superficially via Sapp's plexus.
From where they drain? Which part of breast? Tell me in particular. Superficial, from where they drain?
Nipple areola complex.
No. Superficial is from the overlying skin. Okay. Deep is from the parenchyma and the nipple areola complex. I wanted to make this sure. Okay. That's why I asked you. Okay. They drain to where they drain? 75% to the axilla, and then
axilla, and 20 to 25% into the internal mammary group of lymph nodes and supraclavicular.
Okay, fine, good. So Burke's levels and all, no? Okay, that we'll discuss in the later in the operation. Okay, go to next slide. Okay, no stuff. So that's okay, Nishanth.
Yeah, I think we can go on to the next one.
Next, yeah. History of tuberculosis is very important. Okay, and here also one thing we should remember: tuberculosis is such a disease; it can present like anything and everything. Okay, so in any case, we have to suspect tuberculosis and should rule out that first. So that history is very important. Okay, what type of diet you are interested in this particular case?
Diet.
What are the risk factors?
Risk factors
for CA breast.
Risk factors are, sir, like early menarche, late menopause, nulliparity.
Those are hormonal. What are the dietary risk factors?
Sir, fatty food, high fat diet, high cholesterol, low fiber diet.
Okay.
No, nothing related to low fiber diet and all. That is only for CA colon.
No, they are.
Yeah, please be specific. High fatty diet is a risk factor. Low fiber diet is not a risk factor.
Okay.
Okay, yeah.
Okay, addictions. Okay, fine. Next. Okay, menstrual is very important. Okay, so tell me, when you call it early menarche?
Sir, 12 years.
So late menopause?
55 years.
Very good. So, and first childbirth, when it's like
more than which age is it more risky?
Or 34, 35.
35.
Okay, good.
Yeah.
So why
you
all
shouldn't give us multiple options like 30, 34 and 35.
Why all these problems? Like why are these risk factors? How they cause risk?
Because of unopposed action of estrogen.
You know this Corman's hypothesis, right?
Or just have heard, but not about
the
much.
Same thing. Corman's, this name, what you told is right.
Okay.
More ovulatory cycles, okay, and leading to unopposed estrogen action. Okay, it's called Corman's hypothesis. So, what are the other risk factors? Early menarche, late menopause.
Nulliparity, family history, genetic predisposition. Then we have
in menstrual this thing and menstrual and like what is obstetric history. Maybe.
Okay. Hormone replacement therapy.
Okay.
Then we have like lack of breastfeeding.
Okay.
You
know Gale's risk assessment model, you know?
Yes, sir.
Tell me, what all
the components of Gale's are age, generalized age, then age of menarche, age of first childbirth, then we have previous biopsies, TPRs and family histories.
Okay, good. Okay. Next, go to next slide. Full-term normal.
I have an objection with this slide in the very first line, Kaustubh. Can you tell me what it is? Second line. What does G2 mean, Kaustubh?
Gravida.
What does gravida mean?
Yes, this means that she's pregnant now. So we should not consider this in this case. Yeah. Okay.
Okay, keep this
Just
basic
kidding,
idea
okay?
in
Okay.
just keep this
Yeah.
basic idea in mind.
Yes.
Gravida can never be the same as para.
Yes.
Okay? Yeah.
Yeah.
No history of abortions. Okay, good.
Okay, why is full term important, Kaustubh? What if she had any abortion? Does it make any difference to the CA breast, risk of CA breast?
Yes, sir. Because full-term pregnancy has been seen to reduce the risk of malignancies, to reduce the risk of cancer, breast
What
cancer.
happens? What happens? Why? What about abortion? Does abortion also reduce the risk, or is it the same risk as the general population?
Abortions.
It doesn't.
I guess it
Okay.
doesn't.
Yeah, it doesn't reduce the risk. It is the same as that of a normal female. Okay. What happens at full term pregnancies? You have something called as a terminal differentiation of the breast ducts. So apparently this is more protective when compared to a normal breast. So you have this terminal differentiation will happen only at full term. So if you've had an abortion, the breast does not have that protective factor what it has at a full term pregnancy.
Okay.
So you asked about previous surgeries. What are the surgeries you'll ask about particularly? Want to know about? Kaustubh?
Sir, previous surgeries में
You just told me something in Gale's risk assessment model.
biopsy, sir. Previous biopsy.
Any other in general also? Any other surgeries? Ladies. Hysterectomy and MTP. Okay.
Okay.
So what other which other cancer has got a similar risk factor in ladies? And opposite, another cancer has got quite opposite risk factors. Endometrial cancer, endometrium and breast has got similar risk factor, like that is unopposed estrogen, and this one, what CA cervix has got quite opposite, right?
Right. Okay.
Correct. Next. Go to next slide. Family. Okay, important. So no history of breast. Okay, tell me some familial conditions or syndromes you know of, which includes breast cancer.
Sir, P53 gene involvement, so Leishmania could be one cause. Then we have Lynch syndrome, hereditary non-polyposis colon cancer.
Very good.
Cowden syndrome, PTN mutation. Then anything else we have? Yeah. ATM is seen, but I don't know whether ataxia telangiectasia has any relation with it.
So can you know the incidence? How many familial, how many sporadic, and how many hereditary? You know, any rough idea?
No, sir.
Most commonly, breast cancers are sporadic ones. Okay, about you remember like 70, 20, 10. You remember? Okay, 70% are sporadic one. Okay, and nearly 20% of the breast cancers are familial, and only 10% of the maybe hereditary. Okay, so you have to ask the in family history what you ask in another thing you didn't ask. Breast cancer related deaths you asked, but another any history of breast cancer in the first degree relatives, overall first degree relatives again.
Who all are the first degree relatives, Kaustubh? He's there, or have we lost him?
Oh, he's there. Kaustubh?
Hello.
Yeah,
Am I
yeah, we can
audible?
hear you, Kaustubh.
Yeah, I
Yeah,
Yeah,
guess
tell
yeah.
the
us.
range was disturbed, I think.
That's okay,
Sir,
dear. That's okay.
sir,
Tell us what is.
maternal relatives, direct maternal relatives or first degree.
Can you specify? First degree.
Yeah,
Mother, sister, and daughter.
daughter. Okay.
Okay.
Yeah. Okay.
Is that okay?
Okay, sir. Okay.
So Barca, can you tell about something about Barca 1 and Barca 2?
I was just about to ask that.
Yeah, yeah.
Start off from which chromosome they are.
Ah,
What is the
Okay.
percentage of
Okay,
malignancy
sir.
in BRCA1 and BRCA2?
Okay. BRCA1 is on long arm of chromosome 17. It's autosomal dominant. It has about 50 to 80% risk of cancer breast and is also associated with colorectal, ovarian, prostatic cancers. And
You're talking about BRCA1 or 2?
one, sir.
Okay.
And BRCA2 is on chromosome 13q and has about 30% risk and is also associated with male breast cancers.
Okay,
so
Kishan, you need to clarify on this. My knowledge regarding this is the complete
see,
opposite.
I'll tell you. Barca 1, you're right. It's present in the 17q chromosome, and
Yes.
this is mainly associated with all ovarian, prostate, colon cancers. And mainly, what we need to know about this Barca 1 is this poorly differentiated cancers, and these are usually receptor negative or
Negative.
triple negative type of cancers. Okay, Barca
Okay.
1. Okay, and most commonly we have this invasive ductal carcinomas in Barca 1. Whereas in BRCA2, we have well differentiated cancers. They are present in 13q, BRCA2 gene present in 13q chromosome. We have well differentiated cancers and receptor positive usually. And they can be invasive ductal carcinomas. They are associated with all this ovarian, colon, prostate, pancreas, gallbladder, and what bile duct, stomach,
Malignant
all
melanoma, gallbladder,
melanoma,
stomach
very good, all
cancer.
these things. And like BRCA2 can be associated with male breast cancer. What is the incidence of male breast cancer, Kaustubh?
1%, sir.
1%. Very good. Wonderful. Okay, but they're they're very poorly differentiated male breast cancers and known for high recurrence rates. Okay, poor prognosis
Yes.
and high recurrence rates.
Okay.
And HER2 mutation you told?
Oh, yes, sir. HER2. No, I didn't. HER2 is the thing.
This has got very high HER2 up to 80%. Ductal carcinoma have HER2 mutations.
HER2.
Okay, these are also got
Yeah.
very poor prognosis.
Okay.
Okay.
Yes.
And P53 you told, no? Leave from any?
Yes, sir.
Yeah.
Yeah, this is one thing specialty we should know, especially in they may be asked in MCQs. This P53 mutation can be resistant to chemotherapy. I remember Nishan telling in his class also. These P53 types of mutations are resistant for chemotherapy. I don't know the reason. Okay, and this is the one thing we should remember. And yeah, can we go ahead? Family history, anything else?
Nothing else to be added from my point of view.
Okay.
Now, okay, Kaustubh, just one practical question.
Yes, sir.
What if this patient is BRCA1 or 2? How does it matter to you?
Sir, since there is a genetic mutation present, the patient becomes high risk for me.
She already has a CA breast. What will you do with high risk or low risk now?
Then in that case, it doesn't matter. Just it matters upon hormonal therapy because BRCA1 is triple negative. So definitely we cannot go for a targeted one.
No. See,
It's
BRCA1 has higher chance of being triple negative. There is no hard and fast rule that it has to be triple negative. Okay.
Okay.
And once you have a CA breast, just because BRCA1, are you not going to do what is that ERPR status after doing a core needle biopsy?
Yes, we are going to.
Yeah. So in my point of view, okay, more than her, you're supposed to protect her daughters or her,
Daughter also,
like
yes.
she doesn't have. But if she had a daughter, you'll be more concerned about her and probably offer her prophylactic mastectomy, provided she is BRCA1 positive.
Okay.
Okay, yeah. Go ahead, Kaustubh. I think you have some. Okay, from your summary, it's either what's your most common diagnosis right now? What do you think it is?
It's a malignancy of breast.
Okay, fair enough. Anything else? Any other possibility? With a lump
Sir,
and an ulcer.
Phyllodes tumor.
Okay. We'll get to that in examination. You've actually covered it, but we'll get to that there. Yeah, I think you can
Okay,
carry
sir.
on with the examination. Kishan, anything to add?
Yeah. Summary, he could have added like post-menopausal. That gives a better this thing. Okay, 56-year-old. What I thought is,
Yeah, just
no?
go one slide back, Kaustubh.
Yeah, that's important, no? Post-menopausal
Yes.
for management, whether it's important or not. Kaustubh,
Yes, sir. It is
all the
important.
terminologies or all the like points in favor of your diagnosis and for even for management that you should include in summary. Okay.
Correct.
Yes.
Okay.
Okay.
Good. Next. Yeah, someone asked about what is it? What is the difference between familial and hereditary? Okay. So familial is like in the family and it runs in families and also has got some environmental factor as well. Whereas hereditary is one specific type of family which follows one inheritance pattern, like we say autosomal dominant, recessive, and all. No, if that pattern is followed, then we call it as what is that hereditary pattern, or else just a familial pattern. Okay, that's the answer. Any other doubts at the level of history? Any other doubts? Most of them Nishanth has already answered. Nishant, did you find any doubts? I was not
Nothing
looking
much.
at the.
No, I think they were only asking for us to repeat. We'll do that at the end. And I think Shruti or somebody even repeated that Cooper's ligament. That was their
Yeah,
question.
she did nicely. Yeah. So we can go ahead with the examination. Good.
Okay, sir. The patient was examined in sitting posture with both the hands on the sides in adequate daylight with proper informed consent and in presence of a female attendant. The patient is conscious, cooperative, and well oriented with time, place, and person. Karnofsky performance score is 90, well nourished with BMI of 30 kg per meter square. So, my patient is obese, well hydrated, and febrile.
She's overnourished, not well nourished.
Overnourished. Yeah. Pulse rate is 68 beats per minute on right radial, regular in normal volume and character. Blood pressure is 124 by 72 mm of mercury on the right side in lying down position. Respiratory rate is 18 breaths per minute. There is no pallor, icterus, cyanosis, edema, or clubbing. The patient was adequately exposed up to the waist and examined, maintaining proper privacy in presence of a female attendant. Inspection, the left breast appears larger as compared to right. There is a single visible fullness in the upper outer quadrant of the left breast that appears more prominent when she was asked to bend forwards. There is an ulcer on the overlying skin, which is in the upper outer quadrant of the left breast, size of 3 by 2 centimeters, well defined in shape and margin, everted. The ulcer extends superiorly 3 centimeters below the mid clavicle, medially 0.5 centimeter from nipple areola complex, inferiorly 0.5 centimeters from nipple areola complex, and laterally 1 centimeter from the anterior axillary fold. The floor is red with some slough but no discharge or bleeding. There are no any dilated veins, no satellite nodules or pseudo orange. There is no dimpling or puckering of the skin. The nipples are at same level and do not have any discharge or retraction. Areola are normal. There are no any cracks, eczema, or ulcer of the areola. Right breast is normal. Axillae are normal. There are no any swellings in the bilateral axillae or the supraclavicular region. On palpation, the right breast is normal. Left breast, the local temperature is normal. All there is an ill-defined lump in the upper outer quadrant of 6 by 6 centimeter size, uneven, hard, and non-tender, fixed to the skin, moves with the breast but is not independently moving from the breast, not fixed to the pectoralis major or the chest wall. The ulcer is non-tender, hard, located in upper outer quadrant. Extent is confirmed as per inspection. Then the margins are indurated, but the induration is limited to the margins. The ulcer cannot be separated from the skin and is fixed to the lump according to the probe test. NAC, that is nipple areola complex, is normal. On regional lymph node examinations, both the axillae were normal. There were no lymph nodes palpable in either of them. No lymph nodes are palpable in supraclavicular region as well. On systemic examination, cardiovascular system is normal with S1 and S2 heard. Respiratory system is normal, vesicular breath sounds. The CNS examination is within normal limit. Per abdominal examination is normal. Per vaginal and per rectal examination is normal, and the examination of spine is also normal. So my provisional diagnosis: a 56-year-old postmenopausal obese lady with a painless lump in the upper outer quadrant of left breast and progressively growing ulcer over the skin with everted edges and induration. No other skin changes, chest wall involvement, not associated with lymphadenopathy. Most likely diagnosis is malignancy of left breast of stage CT4N0M0, that is stage 3B.
Perfect. Wonderful. Wonderful. Very good. Okay. Kaustubh. So see, dear members, it should be like this, especially that diagnosis and summary is done wonderfully. Please, we can follow that. So tell me that you're telling about obese and all. So I want to know whether you really done or not. Tell me the grading of what is that?
BMI.
BMI. Yeah.
Okay, sir, basically BMI we calculate with the formula, and then normally it has to be 20 to 25 kg per meter square. If it is
For Indians, I think it's lesser. I don't think it's 20 to 25.
grading, BMI grading, I think okay. Normally it is something like 18.5 to 25
Yeah.
something in
Yeah.
Indians, and
Yeah. Yeah.
underweight is less than 18.5,
Okay.
and overweight we consider from 25 to 30. Obese is considered more than 30.
Yes. Pre-obese and obese. Okay. Then some
Yes.
morbid obese, very morbid obese. Also. See some things. Yeah, like this. That GCS scale and this what is BMI index. Some things are and Kupaswamy classification. We just tend to say like that. When they ask in details, we'll be not knowing. So let's not do that. These are the inevitable questions, and inevitable will be taken in all the cases. So at least 2-3 charts will better know these. Okay. If you don't know, let's better not mention it. Clear?
Okay, okay.
Okay. So good. Next, go to the next slide. Yeah, Nishanth.
Yeah, one second. The slides are changing. Go to the next slide, Kaustubh. No, where is your general physical, that respiratory rate,
Yeah.
pulse?
Yeah, this.
Okay. What is the importance of respiratory rate? In a patient with CA breast, if respiratory rate is high, what do you start thinking in terms of?
Pleural involvement.
Yeah, so what happens? What do you mean by pleural involvement? What exactly am I looking for?
I am looking for pleuritis, pleurisy.
No, can pleuritis or pleurisy cause increased respiratory rate? It will actually cause decreased. Because
Decrease.
the patient is having pain every time he breathes, he will have shallow breathing and less, his respiratory rate will be less. No, because the more he breathes, the more it pains.
Yes.
Yeah, so what else can it be? Effusion, pleural effusion.
Yes.
Okay. Yeah, go on to the next slide. Nothing much to add in this slide. Maintain proper privacy in the presence of female attendant. Yes, with consent. I think you had already mentioned the consent before. Yeah, go on.
Yeah.
Go on, Kaustubh. Next slide. How did you say that the left breast is larger than the right? Based on what did you come to this conclusion?
Bilateral examination.
How? Is there a way of measuring the breast, like volume of breast? There's nothing like that, no?
No.
Yeah. So somebody's already answered. You're going to look for the position of the nipple areola complex.
Yeah.
Okay, so that is how you see whether both breasts are equal in size or one is larger than the other, based on the level of the nipple areola complex. And see, the whole point of using the terminology fullness is when it is vague. Okay, if it is very obviously defined, you are going to say it.
Yes.
Fullness means it is vague. You don't know what is it. That's why you're using the terminology fullness. So when it is vague, you can't use the terminology like single. Okay, if you're saying single, that means you can obviously see what it is. Then don't you say fullness. Say there is a single lump and describe the lump. Otherwise, just say fullness. Don't say single.
Okay.
Okay. And what were you looking for when you asked the patient to bend forward?
Sir, bending forward, if there is a latent nipple retraction, when the patient will bend forward, the nipple retraction will become prominent.
No. Nipple retraction becomes prominent on raising the limbs up. On raising both your hands up, the Cooper's ligament gets stretched. Okay, so that time you will actually look for the nipple retraction. What were you looking for on bending forward?
Sir, your chest wall involvement.
Correct. So what are the contents of chest wall?
Ribs, ribs and the intercostal muscles, but pectoralis muscles are not to be included under the chest wall.
Yes,
Correct.
attended your classes, Nishanth.
Good. I know. Just
He was
like a
expecting
revision.
this question. Yes, prepared.
Okay. So on bending forward, did you expect you said here left breast is more prominent when she bent forward?
Yes.
Okay. So according to you, it's fixed or not fixed to the chest wall?
Not fixed, sir.
Okay. If it was not fixed to the chest wall, which breast will fall forward? Okay, sorry. If it is fixed to the chest wall, the normal breast will fall forward or the abnormal the breast with the lump will fall forward?
Normal will fall forward if it is fixed.
Yeah. So at which position do you look, see and tell? You're standing right opposite the patient or you're taking some other position and looking at it?
Where you will stand when the patient leans forward?
Right side, laterally.
Either side, right or left, to the side of the patient at the level of the nipple areola complex. If you bend forward, look at the level of the nipple areola complex. Obviously, one nipple will be higher up and one will be lower down. Whichever is lower down is the normal one which is fallen forward. Or it can even be an abnormal one which is fallen forward. But if you are the breast with the lump, the nipple is at a higher level when compared to the other breast, that means it is involving infiltration into the chest wall. Okay. Then you have said there's an ulcer over the overlying chest in the upper outer quadrant. Size is 3 into 2 centimeters. Shape and margin are well defined. Edges are everted. Okay. Please move on to the next slide.
How do we differentiate? That's in palpation. Okay. Anyway.
Yeah. He's mentioned that.
He told, okay.
He's mentioned it there. Yeah. Go on to the next slide, Kaustubh. Superiorly, medially, inferiorly, and laterally. Okay. Floor also you have mentioned, red with some slough but no discharge or bleeding. What does dilated veins indicate?
Sir,
what all conditions of the breast can you have dilated veins?
Prominent dilated veins.
In case of Fallot's tumor, we have dilated veins.
Very good. Any other thing?
Sir, if there is a what that disease is called?
Very rare, but still.
Thrombophlebitis, Maunders disease.
Okay.
Yeah.
But any rapidly progressive sarcomas, although rare in breast, angiosarcomas, we can have dilated veins, and even if there are huge breast abscesses, huge breast abscess also, there can be prominent dilated veins.
Whenever there is a lot of inflammation with hypervascularity, you can have dilated veins. So breast abscess, even a CA breast which is very vascular because there's an ulcer, or if the ulcer is infected, you can still have dilated veins. You told me something called Maunders disease, thrombophlebitis. Which veins do they normally involve? Do you know the name of the vein? Somebody's flipping through pages. That's you only.
No, sir, I don't have a book.
Superficial veins.
Yeah. You can have the lateral thoracic vein, the thoracoepigastric vein, and the superficial epigastric vein. These are the veins which are commonly involved in Maunders disease.
Okay.
What is serocystic disease of Brody? Sounds big, but nothing actually. What is
Brody.
cystosarcoma phylloids? Same.
Phyllodes tumor. It's the same thing.
Okay, this is what happens in your entrance exam. We'll be knowing the answer, but still we can't answer because they just ask the other names. Okay. What is a Popper's ligament? They ask.
Okay.
What is Popper's ligament?
Inguinal
What
ligament.
is Popper's ligament?
Yeah.
Inguinal ligament.
Yeah, that's how it is. Okay.
Yeah.
So okay. Go next. What is this? Veins. Okay. Satellite nodules. What are satellite nodules?
The satellite nodules are like skin infiltrations.
Sorry.
Yeah.
Skin infiltrations.
Okay. So what exactly are they? They are a form of skin metastasis. Okay. So basically, if you have a tumor at one place, it eventually has to go to the lymph node. So in between, due to some resistance, if they form a lump there, before it reaches the lymph node, you call it as satellite nodules. Okay. So these.
What is cancer MQRSA?
Yeah.
Sir, cancer incuracy is there are multiple cancerous nodules that infiltrate to the skin and they look like a shield like infiltration on the skin.
Where else you get these satellite nodules? Any idea?
I was just about
In
to
which
ask
other
you that
condition?
question.
Which other condition? That can happen even in breast also. Like this only. It can present like this only. With an ulcer.
Okay.
Okay, if not ulcer, something black.
Yeah, something
Give me
black.
an
Yeah.
example.
Melanoma.
Yes.
Very good.
Okay. So just to
Black.
clear for your benefit, in melanoma, you have something called as the primary lesion, and any lesion that is a secondary lesion within 2 centimeters of the primary lesion is called as satellite nodules, and anything beyond 2 centimeters but before the lymph node is called as in-transit nodules.
Transit nodules.
Okay, you have the primary lesion, you have satellite nodules, which is immediately within 2 centimeters. If it is beyond that, it is called as in-transit nodules before it reaches the lymph node. Once it reaches the lymph node, that means you need to take out the lymph nodes as well. Okay. Now, Kaustubh, one thing I missed here is you have not mentioned about dimpling or puckering. Have you mentioned it?
Yeah, he's
Yes,
no
sir.
dimpling or puckering. Next. Just last line.
Yes, sir, the last line.
Okay, fine. Sorry, I didn't see that. Yeah, now here you have to mention, did you ask the patient to raise her hands?
Yes, sir.
Have you mentioned it in the slide? If you have, I've probably missed it.
Not in the slide.
Yeah, you should. Okay, it's an important part of the examination. And what are you looking for when you ask the patient to raise both their limbs, upper limbs? This one only, dimpling or puckering,
Dimpling
or
and
even
the
nipple
lump not to be
retraction.
one proper.
Yes. Okay. And
Yeah.
apart from that, you're going to look for the inframammary fold. Normally, you can't see the inframammary fold because the breast is slightly pendulous.
Yeah.
Okay. And in the inframammary fold, what are you looking for? You're looking for Mondor's disease. Your thrombophlebitis and all will usually be seen in the inframammary fold.
Okay.
So in inspection, to look at the inframammary fold, you ask the patient to raise their hands. There are 3 things which can happen. One is your breast lump will become prominent, or your dimpling, your puckering and your nipple retraction will become prominent. Your axilla will become prominent. So if there's any lump in the axilla can be seen. And the last one is your inframammary fold. If someone asks you this, don't get excited and tell inframammary fold first. Okay, it is the least important and the third one. First 2 are the something related to the breast. Second is related to the axilla. Third is the inframammary fold. Okay, yeah, you can go on to the next slide, Kaustubh. Nipple at the same level, no retraction or discharge. We already discussed the discharge and retraction. Areola, no cracks or eczema or ulcer. Now I'll ask you at this point, how do you differentiate Paget's disease and eczema?
Sir, based on ulcer,
need not have an ulcer.
Sir, basically, eczema will have like itching will be there in eczema, whereas in Paget's disease there will not be itching seen. Matlab,
Correct.
yeah.
Paget's is unilateral or bilateral?
Paget's
Paget's
is usually
unilateral, no?
yes, unilateral.
Yeah, and usually eczema is a generalized condition, so it will invariably be bilateral. Okay.
Yeah.
And in Paget's, you can have an underlying lump. You can or cannot have.
Yeah.
Yes.
Whereas in eczema, you'll never have a lump.
Yes.
If there is a lump, it is Paget's.
Okay.
If there is no lump, it can be Paget's, it can be eczema. That's how you're supposed to interpret that. Okay.
What is the pathognomonic cells of Paget's disease?
Paget cells.
How they look like?
No. Paget cells are.
Yeah, Paget cells.
Then what is seen in Phyllodes tumor? Aren't those also called Paget cells?
Pagetoid cells.
Okay. I thought where you get that orphan ani nucleus? No, that is thyroid.
Papillary carcinoma.
Yeah, Paget cells, you're right. So what are they? How they look like?
So they are large vacuolated cells and they are generally seen in the retipex of the epithelium.
Wonderful.
Excellent.
Large, pale, and vacuolated cells. Okay, very vacuolated and seen in the
retipex. Those are the 3 points. He mentioned all 3 points when he was clarifying it. Right breast is normal. Left breast local temperature. Don't say local temperature normal. You're supposed to say no rise of local temperature.
Why there will be local rise of temperature?
Can this patient have local rise of temperature?
No local rise of temperature, local rise of, why is that?
Sir, this patient can have local rise of temperature because since she is an ulcer, the infection can cause a local rise in temperature.
How?
Sir, infection.
Infection, how? You tell me.
What happens if your patient has an infection? What will the body do?
Even cancer can also have increased, temperature, localized temperature. In cholecystitis also will have. Why is that so?
Sir, because of inflammation, the release of
vascularity is increased. Okay, increased vascularity, same thing. Okay. Vasodilation and increased vascular. Even in cancer, there will be what is that? Angiogenesis. Okay. Increased vascularity will cause this thing. Okay. Next. Okay, I said lump of size 6 into 6 centimeters. Go on to the next one. Next slide, Kaustubh.
Yeah.
What do you mean by uneven? Were you trying to tell us about the surface?
Yes, sir. About the surface and consistency, basically.
But you said hard.
Majorly hard. It is majorly hard, but at some places it is felt like lobules. Some places it is soft. Some places it is hard.
Then what is that called? What consistency? If more than 2 types of consistency are there, then what do you call it?
Independent variable, dependent variable.
Variable consistency. Okay.
Yeah.
Variable. Where else you get variable? Give me some examples for variable consistency. One is in malignancy. They can, you're right. Anything else? Hematoma.
Yes.
Okay. Hematoma can have variable consistency. Okay, like that. Okay, go. What he was asking, Nishanth was asking, what do you mean by uneven? Whether it's you mean to say its surface is uneven, like lobulated?
No, sir. It's consistency. Means it's variable. Actually, it's variable in
consistency. Is variable. Yeah. Okay. Then you mentioned hard. Okay, somewhere it is variable, somewhere it is like hard. Okay, fine. But don't do like that. Don't tell like that. Okay. Mention it as variable. Uneven, most likely to refer to surface. Okay. Where you get this lobulated or bosselated surface usually? In which condition of breast?
Fibrocystic disease. Fibroadenoma.
No. Fibroadenoma is usually smooth. Phyllodes.
Phyllodes tumor. Yeah.
very close or DD, no? That's why we should
Yeah.
rule out that also.
Yes.
Okay, so the ulcer, you have said it moves with the breast, but not independent of the breast. How did you do the test? Kaustubh, you are there?
Yes, sir. I'm there.
Okay,
Moves
I'll
with
tell
the
you. So what is supposed to do is you're supposed to cup the breast with your left hand, and with the right hand try moving the swelling. If you feel the breast also move, because you're holding the breast in the left hand, so if you feel the left hand also move when you're moving the lump, that means the lump is moving along with the breast. If it's a fibroadenoma, only your right hand will move, but your left hand you won't feel any movement because it's moving within the breast but not with the breast.
Okay.
If both, when you're moving your right hand, if you feel some movement on your left hand as well, that means it is moving along with the breast tissue. Okay, not fixed to pectoralis major. So in which direction did you check for mobility of the lump? Perpendicular or along the fibers?
Along the fibers, sir.
Excellent. Here you said margins are indurated, but the induration is limited to the margin. What if the induration had spread beyond and involved the entire breast? What condition would you think of then?
Sir, then it is more likely to be phyllodes.
No. Phyllodes will never have induration. Why do you have induration here? What is the reason for induration?
Sir, fibrosis and more amount of inflammatory reaction associated.
No, it's just infiltration, skin infiltration. Like in oral cavity malignancy,
Yes.
you have a small growth or whatever, and induration beyond it means what?
It is extending. It's involving the mucosa. So
Yeah,
yes,
it's basically it's infiltrating. So same
Yes,
thing here. Okay, so if your inflammation, I'm assuming the margins are inflamed, and if the induration goes well beyond the inflamed region, you have to start thinking in terms of inflammatory carcinoma.
Okay.
Okay. Now coming back to here. Now,
what is inflammatory carcinoma? Which classification? Classification of inflammatory carcinoma. To which stage it belongs to?
Stage
T4.
Sir, it's 4D, I guess. T4D.
Yeah,
Correct.
T4D. Very good.
Yeah. Now coming back to this point, between how do you differentiate between phyllodes ulcer and a malignant ulcer?
Sir, with the help of probe test,
Okay. What do you mean by probe test?
Will pass a small probe just beneath the ulcer. If it is means we can separate the skin from the ulcer, then it is going to be a phyllodes tumor. But if we cannot separate it, then it is more likely to be a malignant.
Yeah. Can you tell me why that is? Why is it that in phyllodes you can separate the skin, whereas in malignancy you can't? What is
because in malignancy the cells are infiltrating into the skin, whereas in phyllodes tumor, that is because of stretching of the skin, the ulcer is produced. Continuous stretching produces trauma.
So when there is stretching, the vascularity gets cut off. It's called as pressure necrosis. And because of the stretching, it tears. So, but there is still a plane between the skin and the lump underneath. Okay, excellent. Yeah, you can go on to the next slide, Kaustubh. Both axilla are normal, no lymph nodes. Okay. Can you tell us what are the Berg's levels of lymph nodes fast?
Yes, sir. Level 1 is lateral to pectoralis minor, and it involves anterior, posterior, and lateral group of axillary lymph nodes. Level 2 is central and rotors group of lymph node, and level 3 is apical group.
No, you have to tell me what is level 1. Is this level 1, level 2, level 3 are defined in relation to what structure?
Pectoralis minor, sir.
Correct. That you have to tell me.
So it is below and lateral to pectoralis minor, then it will be level 1.
Correct.
If it is behind the pectoralis minor, then it is level 2. And if it is above and medial, then it will be level 3.
Excellent. Now we have said there are no lymph nodes palpable in supraclavicular. I'll ask you one question. How does the lymph go to the supraclavicular lymph nodes via CA breast? Through what?
Through apical group of lymph nodes.
So basically it has to go to the axilla and from axilla to supraclavicular lymph nodes, correct?
Yes.
In your patient, if axillary lymph nodes were normal, as in you said there are no lymph nodes enlarged, why did you check for supraclavicular lymph nodes? There are two answers.
Sir, basically one possibility is skip metastasis.
Okay, what is the
And
percentage of skip metastasis? Do you know?
Oh, no, sir.
5%. 5% of the cases where it can skip the axilla and go to the supraclavicular lymph node. And the second reason, more
Sir,
common sense. What is the patient's BMI?
30, it's obese.
Yeah, so if the axilla is filled with fat, you have to palpate the lymph nodes against the rib cage. So if she's very fat, it will become difficult for you to palpate against the rib cage. So even if there's lymph nodes, there's a chance that you might miss them.
Okay.
Whereas supraclavicular is much more superficial.
Yes.
In axilla, I have to palpate deeper. So only for this patient, don't tell this reason for every patient.
Okay.
Okay, for this patient, because she's obese, you can give this as a reason as well.
Yes.
Okay, yeah, you can go on to the next slide, Kaustubh. Per abdominal examination, normal. Per vaginal, per rectal, you have done, it's normal. Examination of the spine. What did you examine in the spine?
Tell in general musculoskeletal system. Okay, better. Sir.
Okay.
What did you examine in the spine, Kaustubh? What are you looking for?
Sir, we are looking for any form of metastasis going to the spine. So bone pain, tenderness basically.
Where? Tenderness where?
In the upper lumbar region.
No, where? Paraspinal, spinal?
Spinal area.
No, it is paraspinal. Okay. I've told this,
Okay.
but I anyway repeat it again for your benefit. What happens is there is no movement which occurs at the lumbar vertebra. Okay, at least in thoracic, and you have either rotational flexion, lateral flexion, or what is that? Bending forward and leaning backwards. At lumbar vertebra, the only movement which can happen is rotational movement. Okay, so you have to forcefully rotate the vertebra. So to do that, you can't press on the spine and try to rotate it. You have to press adjacent to the spine. That means on the spinous process, not the sorry, the transverse process of the vertebra, and try to rotate. So when you press paraspinal region and try to forcibly rotate the vertebra, the patient will have pain. Okay, so not in the spine, the patient might not have pain. Only when you try to rotate it, paraspinal region, the patient might have pain. Okay. Yeah, go on to the next one. Okay, just 1 second. In abdominal examination, what were you expecting?
Sir, for ascites and hepatosplenomegaly.
Okay, and in perrectal examination?
Sir, Blummer shelf.
Okay, now just apart from what are the order in which the different bones get involved in breast carcinoma? Most common is the spine, lumbar vertebra, you said. Next most common? Humerus. After that is greater trochanter, and last is the skull. Okay, amongst the four, vertebra, humerus, greater trochanter, and then skull. Okay, Aditya has asked what is the significance of perrectal examination. If this patient had ascites, that means he already has peritoneal metastasis. That is via lymphatics. That is why he's had distension. So you can have drop metastasis into the cul-de-sac or the pouch of Douglas. So when you're doing a perrectal examination, you can feel nodularity there. That is called as Blummer shelf. Yeah, go on to the next slide, Kaustubh. Okay, so your provisional diagnosis is CT4 what? T4A, B, C, D.
What is T4A? What is T4B? What is T4C? What is T4D?
T4A is chest wall involvement. T4B is skin involvement. So this will be T4B.
Okay.
T4C is both A and B, and T4D is inflammatory carcinoma.
Okay. So how are you going to go ahead, Kaustubh?
So what is 1 second? You are looking at
Sorry,
your
sorry.
diagram. Nicely put. Okay. So can I? What is multicentricity, what is multifocality? It's the most
Yeah.
commonly asked and confused one. So better answer for a benefit of all the members.
Yes, I agree.
Okay, sir. Multicentricity means two different lesions which are more than 5 centimeters from each other. And if it is less than 4 centimeters, then it is going to be multifocal. More than 4 centimeters, it is multicentric.
That's the one definition, but that's given in only in Schwartz, I think.
Schwartz.
But for you guys, it's a different definition for UGs.
Yeah.
Huh? Depending on the pattern, can you tell?
If it is in the same quadrant, it will be multifocal. If it is in a different quadrant, it will become multicentric.
Correct.
So now, I'll give a hypothetical this thing. Here it is axilla is clear, no? M0 and M0. Now
Yes.
imagine there is a swelling in the right axilla.
Okay.
What's your staging? What's your staging now?
Right axilla.
There's axillary lymph node in the right axilla.
Listen carefully to the question.
Carefully, yeah. It's a very general question, okay? So you need to ask me some questions now.
Okay.
There is one. You understood, no? There is one central group of lymph nodes enlarged in right axilla.
Okay.
What is the stage? Because why I asked, because to take up another concept in breast cancer. Important concept.
Sir, if it is going to contralateral side, it will become M1.
Okay, good.
Yes.
So you have to determine, no, whether it's really contralateral or not. So you have to first check the other breast as well. Okay, you have to check the other right breast. Okay, that's called what is synchronous lesion, what is metachronous lesion.
Okay. Sir, it is it based on duration of appearance or something like that?
Okay. What's the duration?
6 months.
Okay. If the
within
lesion
6
arises
months,
from
it is synchronous.
Okay.
And if it is more than 6 months pass between the two lesions occurrence, then it is metachronous.
If it's to the opposite axilla, then it is M1. It's distant metastasis. Okay. Then everything changes. Nishant, okay, no?
Yeah. Just one additional point, if there are any postgraduates for their benefit. If the lump is in the upper inner quadrant and the patient has an ulcer which is just reaching to the midline, and the patient has a right axillary lymph node, it need not be M1 because certain it can go through the skin of the opposite breast and reach that lymph node. So it can be still an infective condition. This is only for postgraduates. For undergraduates, it's way beyond your level of questioning. Don't worry. Yeah. So how do you go ahead, Kaustubh?
Sir, so for breast cancer, we have triple assessment, in which clinical assessment we have already completed.
Yes.
So now we will be doing radiological investigations, which will include imaging and then pathological. So now in my patient, I would like to do a mammography followed by a core needle biopsy with receptor assay. And
what mammography would you like to do? Sono mammography, X-ray mammography, or MR mammography?
X-ray, sir. X-ray.
Correct.
So what is the difference between mammography and X-ray? Sorry, X-ray. Sorry. Usual chest X-ray and chest mammogram.
Have you ever seen a mammogram being done, Kaustubh?
No, sir.
Okay, so then it might be a bit difficult for you to answer.
So
First and foremost, the amount of radiation which is used in mammogram is higher when compared to an X-ray. And in mammogram, what they do is they flatten the breast. Okay, they use either
compression view.
Yeah, either from side to side or from top to bottom. They compress it and then they take the X-ray. Okay, so those are called compression views, and different views you have. You have craniocaudal view and a mediolateral oblique view, MLO view.
In mammography, we use low voltage, high amperage. This is for PGs, they'll ask you. Low voltage, high amperage X-rays. Okay, these are nothing but mammography. And like Nishant told, one mammography equal to 4 chest X-rays. That's the radiation. Radiation used in a chest X-rays 0.1 millisieverts. That's the radiation dose of each chest X-ray. Whereas of a mammography is 4 times. That is 0.4 millisieverts. Whereas that of a CT chest is 70 millisieverts. See,
Right.
7 millisieverts. So it is 70 times. So the radiation dose of one chest X-ray and one CT scan is 70 times difference is there. So before writing a chest CT scan, think 10 times whether it's really required for the patient or not. Okay, it has got high radiation hazard, CT scan and all. So for that sake, I'm telling you to realize the value of that. Okay, so before writing any CT scan, simply don't right and left and right, don't write, prescribe CT scans. So 0.1 millisieverts for chest X-ray, 0.4 millisieverts for mammography, 7 millisieverts high radiation in chest CT thorax. Okay, and yeah, like he mentioned, there are two views mainly, craniocaudal and mediolateral oblique. Then there are some compression views also for better this thing. And one thing is here axilla is not visualized, right? Mammography, Nishant?
Both in both X-ray and in mammogram, you won't see the axilla. It is only seen in
Axilla.
sonomammogram, which is an
And it's
ultrasound
always-
of the breast.
And it's always bilateral. Okay, mammography is done bilateral.
Yeah.
Okay. Yeah.
Okay.
Yeah. Next.
Okay, well, this is one routine question which they're going to ask all of you. Why not FNAC? Why core needle biopsy? What is the advantage of core needle over an FNAC?
Sir, basically FNAC will not help us to distinguish in situ from invasive.
Excellent, 1 point.
And secondly, in FNAC, it's just a cytological investigation. So even receptor status cannot be assessed from that.
Okay, second, one more. Have you heard of grading of the tumors?
Yes, yes, yes.
So that is the third one. Okay, nuclear grade.
Bloom-Richardson grading, you know?
I was just about to ask that. That was the next question.
Same, no, man. You asking me.
Yeah. No, I was building up to that.
We both, yeah.
What are the different things you know in grading system? Have you heard of the Bloom-Richardson grading, Kaustubh?
Yes, I have, but I don't know the components.
Yeah, there are 3 components. One is the nuclear grade, second is your mitotic rate, and the third one is microtubules. Okay, nuclear grade, mitotic rate, and microtubules. Each of them have a scoring of 3. Okay, 0, 1, 2, 3, 1, 2, 3, 1, 2, 3. So the maximum score a patient can have is 9, and the minimum score is 3. Okay, now you have done the staging, no? This staging is based on what classification?
TNM.
AJCC. Okay, AJCC and TNM classification. Do you know of any other, at least the names of any other type of staging?
No.
The staging.
They might ask you only if you answer everything. Have you heard of Manchester staging?
No, sir.
Should know names at least nowadays, not used, but names you should know all these.
That's why I'm not going to go into the in-depth of the staging, but remember there's something called as Manchester staging, which was done earlier for CA breast. That was also done. Okay.
When do you do MRI?
Indications for MR mammogram.
To differentiate between multicentric, multifocal, to differentiate
you can do in
scar.
X-ray also.
Yes, and to differentiate between scar and recurrence.
Okay.
We can go for MR, and in younger females.
High risk patients, yeah. Okay. Then patients with breast implants.
Breast implantation.
It's a gold standard. Okay, gold standard for imaging in breast women with implants, and you like scar and this thing, and mainly for recurrence also. Okay.
Yes.
Clear. So you know BIRADS. Recently, one question was asked in what is benign lesion in case of a BIRADS? Which grade is that? Like that directly ask you. Nowadays in NEET, they're no more asking to name you the classification or name you this thing. They're asking one particular in Ranson's criteria. They'll give you some components. Now tell me the Ranson's criteria. Like that, they're going one step ahead now. Nowadays in MCQs and in your entrance exams. So we should know even the components of the each. So tell me, when do you call benign lesion in case of mammography? Which grade is that?
Sir, grade 2.
Very good. Okay. So when you say breast carcinoma, which grade?
5.
Okay, very good. Wonderful.
Yes.
Okay.
5 or 6?
5. 6 is biopsy proven.
Yes, 6
Yeah,
is
they're saying breast
known
carcinoma,
biopsy.
that means you've already confirmed. I'm
No,
assuming.
no. 5 is on mammography. It is
3 is
Suggestive of
suspicious,
malignancy.
3 is probably benign.
probably benign. 4
4 is
is
suspicious of malignancy. 5 is malignancy.
5 is highly suspicious of malignancy.
No. Nothing called high. Okay, highly suspicious and this is same.
Okay.
No, there is nothing called highly suspicious.
Okay.
It's a 5 is breast carcinoma on imaging, but we are not sure until biopsy is done.
Okay.
Nishan, please. I may be wrong.
No, I forgot.
No arguing with you, but
I have to
as
check
per I-
BIRADS.
Yeah.
That's right.
So we'll go to further management. You want to give him some scenarios, Nishan?
Actually, I'm getting a call. Can I please take it?
Yeah. Sure. So yeah, Kaustubh, you will.
Yes, sir.
You have a what is this? Okay. Okay. How will you manage? How will you treat now this patient? This index patient, how will you treat first?
Sir, being at stage 3B, I would like
Okay.
to give a neoadjuvant chemotherapy followed by modified radical mastectomy and followed by adjuvant radiotherapy.
Okay. So neoadjuvant, what you would like to use?
Being a post-menopausal woman, I would like to go for aromatase inhibitors.
Okay, like?
Or like we can go for letrozole and anastrozole, which are non-steroidal ones.
Okay.
And
Then? Okay, after neoadjuvant?
After neoadjuvant, we will go for modified radical mastectomy.
Letrozole, anastrozole, what is that?
These are non-steroidal aromatase inhibitors. They are hormonal. They are used for hormonal therapy.
It's for hormonal therapy. Chemotherapy?
Chemotherapy, sir, we can go for ACT regimen.
Okay. What is that ACT regimen?
ACT is adriamycin, cyclophosphamide, and taxane based, like paclitaxel.
Okay. So mainly taxanes you should use, no? In case of post-menopausal, that's what you mean to say.
Yes.
Okay, that's neoadjuvant chemotherapy. After that, any yeah.
Yes. After that, MRM.
MRM. Okay. Any role for breast conservative surgery here?
Sir, in this case, no, because the lump breast ratio is quite high. The lump is more than 1 centimeters in this case. So I don't think so that
After neoadjuvant chemotherapy, if it comes down, you should do the re-evaluation. No, by that time, if it is 1 centimeter.
So Kaustubh, basically what is done is, before giving neoadjuvant chemotherapy, they insert needles. Okay. Like I don't know what needles they are. Some metal alloy
Titanium,
there. Titanium needles or clips to the borders of the lump. Okay, and then they give chemotherapy. The lump will shrink. So even though the lump is shrunk, wherever the needles are there, no, that is up that entire extent you have to remove. Now in this patient, it is possible because she is obese. So I'm assuming her breast tissue is pretty abundant when compared to the lump, and the lump also would have reduced in size. So you can possibly do a breast conservation surgery post neoadjuvant chemotherapy.
But your answer should be here. You're right. Modified radical mastectomy. If the examiner asks, only then okay. If it's
possible?
feasible in your setup, only then you answer. Okay. Usually in Indian scenarios, it's difficult. Unless the examiners ask, don't mention about this. Okay. So okay, then adjuvant again you will give chemotherapy, radiotherapy, and depending on the receptor assays, you'll give hormone therapy. Okay. So tell us more about MRM, modified radical. For you, this is important. Modified radical mastectomy. Tell us how you do.
Modified radical mastectomy. Basically, we give a Stewart's incision And after that we do a wide excision with a, I don't know the margin actually. Okay, we do a wide excision, and along with that we will remove level 1 to 3
Wide excision of what?
of the lump
Lump or breast? You remove the
of the
entire
breast,
breast.
entire
Entire
breast.
breast tissue is taken out.
Including the nipple areola complex.
Yes. So this is basically the Pate's
What
type
you
of
told? Okay.
MRI.
Okay, Pates. Okay.
Huh.
Any other modifications you know?
Yes,
Nowadays
sir.
do they do Pates routinely, or?
No, sir. Generally preferred is ochinclos and scalons.
Okay, what are those?
Scalons is like we preserve pectoralis minor muscle. We don't remove that. We usually retract the muscle. And ochinclos, it is almost same like scalons, but we don't
I'll
remove
tell you.
level
No,
3
don't
as
get
well.
confused. Pates, we divide the muscles. In radical, we remove the muscle. In Pates, we divide the muscle. In scanlons, we split the muscle. Whereas in ochinclos, we just retract the
Retract.
muscle.
Yeah.
Did you understand how we
Yes, sir.
improvised
Yes, sir. Yes, sir.
to preserve the muscle? Did you understand?
Yes, sir.
Remember
Repeat.
PSA, prostate specific antigen. Pates, Scanlon, Auchincloss in the same order.
Pates,
Go on.
divide.
Divide.
Scanlon,
Scalons is
split.
split, and ochinclos is retracting.
Yeah.
Okay.
Understood?
We are becoming more and more conservative as the days
Conservative.
progress. Yeah.
Yes. Okay.
So, and in Pates, you are right. They used to do till the level 3, but in Scanlons and Achinclos, we nowadays we do only level 1 and level 2. Can you tell any? Do you know the reason why we are not doing such aggressive lymph node dissection and all?
Sir, because if we remove the entire amount of lymph nodes, there is possibility of
Lymphatics.
post-surgical lymphedema.
Wonderful day. So, on long-standing lymphedema, what can occur?
A lymphangiosarcoma can develop,
Perfect.
which is
Other name
called
for it?
Stewart-Trevis syndrome.
Excellent.
So, what are the levels of lymph node? Like, what are the boundaries of? Since you answered all this everything,
Axilla.
we want to know what are the boundaries of lymph node dissection.
I have other questions, Kaustubh, don't worry.
Okay, please. You are not asking.
No, not this. After you finish breast, we'll go into how to manage malignancy and metastasis.
Okay, fine. Yeah, we have to improve, because otherwise all the sessions are getting very similar ones. You know or not, Kaustubh?
So for lymph node dissection,
Till where? What are the boundaries of lymph node dissection?
Superiorly axillary vein, inferiorly up to the bifurcation of the latissimus dorsi pedicle. Anteriorly, you have the pectoralis major, and
yes.
posteriorly, you have the latissimus dorsi.
Okay,
this is the boundary, and you have to clear all the lymph nodes here. And you're supposed to visualize the long thoracic nerve of Bell and the latissimus dorsi pedicle and the latissimus dorsi nerve. Nerve to latissimus dorsi. That's also called the thoracodorsal nerve.
ABC.
Yeah.
So you told adjuvant radiotherapy. After that, you have to give the chemotherapy, right? And you told also adjuvant radiotherapy. What are the indication? Does it really required here, radiotherapy? What are the indications for radiotherapy?
Sir, in breast conservation surgery.
Okay, good.
Then if the surgical margin is positive.
Positive, very good.
And if there is a high-grade lesion or more than 4 lymph nodes, lymphovascular invasion and all those things.
Okay. Then again, if the muscle is involved, pectoralis muscle, and if the axillary clearance is not done properly, okay, and one more, I think internal mammary, for if the tumor is in Nishanth, I'm not sure about this. If the tumor is in the upper and inner quadrant, we give the RT for the internal mammary nodes, I think, because we can't clear them.
That will come under your chest field radiotherapy.
Okay. So what is the dose, breast for breast irradiation? 5,000 to 6,000 centigrades. Okay. All is not so important anyway, but I think no harm knowing. Okay, please proceed, Nishanth. You ask your questions. We'll finish off.
Yes. Okay. Now let's go into management of metastasis, Kaustubh. Let's start with the respiratory system. If the patient has pleural effusion, with the case of CA breast having pleural effusion, automatically the patient falls into M1 category. Okay. How will you manage the pleural effusion?
Sir,
Okay.
by placing a intercostal drain.
Okay. So before putting an intercostal drain, the question should be, is the patient tachypnic or not? Is he in respiratory distress? I'll tell you why. If the patient has pleural metastasis and you put an intercostal drain, as long as there are pleural metastasis, he'll continue to lose fluid, correct?
Yes.
So the patient will become nutritionally depleted.
Yes.
So don't put an ICD unless the patient is in respiratory distress, because there's not an acute fluid collection. It's gradual over a period of time.
Okay.
So the patient can actually tolerate a good amount of pleural effusion if it is secondary to metastasis, because it is over a period of time it has happened. It is not sudden infection and the infection has caused pleural effusion. It's not like that. So if the patient is in distress, then yes, you have to put an ICD drainage. But as long as the ICD is there, he'll continue to lose fluid. So what do you do then? How do you reduce the pleural space? Is there any technique that we do?
Sir, pleurodesis.
Excellent. So do you know of
Which
any
other condition we do? Which other benign conditions you know? Which commonly we do? Pleurodesis, chronic empyema. Okay, empyema.
Yeah.
Okay, we do pleurodesis.
Yeah. So what are the agents? Do you know any few agents which can cause pleurodesis?
No, sir.
Talc,
Talc
bleomycin,
powder.
tetracycline.
Talcum powder.
Not talcum, talc.
Talc powder. Talc.
Talcum is for babies.
Talc.
Okay, talc, slurry of talc. That's what they call it. Okay, it has some aluminium, magnesium, silicate, some combination of these three. Okay, so this now what about bone metastasis? How are you going to treat them? Have you heard of bisphosphonates?
Yes. Yes,
Yeah.
sir.
So you treat them with bisphosphonates or external beam radiotherapy. Localized to only that skeletal bone. Like if the humerus, give radiotherapy only to the humerus. So sometimes there is little regression of the bony tumor and the patient will actually feel better. What will happen if you don't give radiotherapy? You will say anyway she's M1, don't give. What will happen? What can happen if the patient has bone metastasis?
What will it lead to?
Is the bone strong or weak?
It's weak. There will be pathological fractures.
Yeah. Excellent. So their quality of life and all will become very poor if they have a fracture. They can't use their limbs, and long-term fracture can actually impinge on nerves. They can have paralysis of that particular limb. So you should always treat them. Okay. So what about hepatic metastasis? Can you treat them or not?
Liver.
Yeah. You have to keep it in mind. At the end of the day, these metastases are still metastases from the breast, which are responsive to ER and PR, not radiotherapy. You can't give radiotherapy inside the abdomen. You'll cause radiation enteritis. That is why your colon carcinoma and all, you don't give radiotherapy. You give radiotherapy only for rectal cancer.
Yeah.
Rectal cancer, because there is no small bowel in that region. Okay. That's why you give only for rectal cancer. For normal CA sigmoid or CA cecum, have you read of radiotherapy?
No.
That's why, because it can cause radiation enteritis. The small bowel can get affected. So coming back, visceral metastasis secondary to CA breast invariably are ER/PR positive. So you can still treat them with tamoxifen and anastrozole, and they will have a pretty decent quality of life. Although their outcome is poor, you can give them palliation and they will be comfortable for as long as they live with simple tamoxifen and anastrozole.
Okay.
Yeah.
Kaustubh, for
Yes, sir.
postmenopausal, you told aromatase hormonal therapy you give this aromatase inhibitors. For premenopausal,
Selective estrogen receptor modulators, SERMs, like tamoxifen,
Very
raloxifene.
good. So I want to know what are the side effects of tamoxifen. This is a very important, commonly asked question. Side effects of tamoxifen. Very good.
Osteoporosis and endometrial carcinoma.
Yeah, important. Okay.
Gallstones,
And
DVT.
yeah,
That also
DVT
have to
and
say.
bone pain. Even see, no need not be always bone metastasis. Also, even a tamoxifen also can cause bone pains and these hot flushes and other things. Okay.
Yeah.
So we should know the side effects of commonly used drugs. Like in chemotherapy, what all drugs we use? Like CMF, AMF, and all you told. So CMF, cyclophosphamide. That's a commonly given chemotherapeutic agent. What are the side effects? You know, common, very important one. Classical side effect of cyclophosphamide.
Thrombosis. No, not thrombosis. No.
They'll come with blood in the urine.
Okay, hemorrhagic cystitis.
Wonderful, my dear. Wonderful.
Yeah.
And also it can cause neutropenia and our what is that? Bone marrow suppression. Okay, all this.
Okay.
You
Okay.
should know. And any this HER2 antibody, anti-HER2, you know.
Yes, sir. Trastuzumab.
So depending on the receptor status, we give. What are the three receptors? We say triple negative, triple positive. What are the three receptors?
ERPR and HER2 new.
So if HER2 new positive, then what we give?
Then we give trastuzumab.
Or you know,
Or
Herceptin.
Herceptin. Yeah.
Mainly for sir, you know, another one more question. For brain metastasis, which drug is used? Nishant, you know?
I honestly don't know. There.
No, I know, but this
yeah.
question, right? Important one.
I don't know.
For brain metastasis, one I think lapatinib. I think one monoclonal antibody is there. Lapatinib that is used specifically used for brain metastasis in breast. Okay, lapatinib.
Okay.
Any other questions? Any doubts, Nishant? Any questions?
Nothing much from my side.
Any doubts?
Oh,
you were supposed to answer this prophylactic mastectomy, oophorectomy. Will you answer? We can do for not just chemotherapy. There are so many other things also. Like okay.
There's one more question. I think Shravan has posted. When is fulvestrant?
There, I think from YouTube. From YouTube, he's posting.
Stream question. See, fulvestrant is an advanced version of tamoxifen as far as my knowledge goes. If the patient doesn't respond to tamoxifen, then you put them on fulvestrant. Their dosage, their indication, their knowledge is beyond my scope. Because I'm a surgeon, I'm only confined to my specialty. So I always refer them to a medical oncologist and they take over. And this ribociclib is also something to do with that. Once you ribociclib.
Right. CD4K,
yeah,
CD6.
These are all cyclin inhibitors, correct?
Cyclin inhibitors.
So all your tamoxifen, anastrozole, and most of these are actually cyclin inhibitors only. They're one of that D1 or some cyclin inhibitor. So this is also a side or an adjacent drug to it. So if none of your tamoxifen and all work, you'll eventually start them on these drugs.
Yeah.
And what was the question?
I already answered. Bloody discharge involving a single duct or multiple duct.
Yeah.
You can't make it clinically.
Clinically, if you're very, very careful and if you're lucky, sometimes you can. If it will just
along
be
with other signs.
Yeah, one small dot. If you see, invariably it is single duct. But when you palpate and squeeze, if you see it coming out through multiple areas like this, like a flower, it will come out like this. Then it is multiple duct, but very, very difficult to make out clinically.
We do ductography.
Ductography.
Okay? And treatment is microductectomy. Okay.
Yeah. And what was the question on prophylactic mastectomy? I forgot. What exactly was the question?
If any high risk patients are there, if mother is this thing for a daughter, BRCA mutations, whether we do prophylactic mastectomy.
Yeah, it's not compulsory. First, there are two options. You can do something called chemoprevention by giving them tamoxifen and watch them carefully. You do a surveillance starting from the age of 25. Okay, clinical breast examination every 6 months, mammogram every 1 year. I think mammogram will be difficult, so you'll have to do an MRI for them because it's a young breast and dense breast. And then if there are certain people who are very apprehensive. They're like, no, you just take off my breast and I'll have some peace of mind. That time you can offer them bilateral prophylactic mastectomy. No axillary lymph nodes, not modified radical, only the breast tissue, whichever is high risk for developing cancer, you can take them off. Ramakrishna Paz, difference between fibroadenosis, fibroadenoma. Both of them are a part of ANDI, that is aberration of normal development and involution. In fibroadenosis, it's a localized region, whereas it's diffuse.
Fibroadenoma is hyperplasia of a lobule. Okay.
Correct. And it is localized to one place.
Cyclical mastalgia, nodule with a cyclical mastalgia is fibroadenosis.
Yeah, that's it.
Any other doubts? A book we can for breast, the best will be to refer Schwartz or Sabiston, because it's a long question as well as definite case. You can refer either. Sabiston is very good. Even Schwartz is also good for both thyroid and breast. Okay, you can refer if you have time. Or any other doubts? Shravan, any doubts in YouTube?
So 1 second, sir, just checking.
Yeah. Kaustubh, very good presentation. Okay, we just took the advantage of your intelligence to ask higher, difficult question. Okay, please. All these are not to your level, UG level.
Yeah.
Most of them were PG level questions, but just to have a good discussion, we asked. Okay, you did really well, Kaustubh, and especially the presentation case was very good. Okay, your case PPT presentation was too good with minimal errors. Wonderful, very well done, Kaustubh. Are you there still?
Yes, sir. Thank you.
Kishan, if you can excuse me, I'm getting another call.
Yeah. Thank you so much, Nishanth. Yeah, so let's end the session if there are no more doubts. Thank you so much, everyone. Tomorrow I'll be taking a class. Tomorrow is Friday, right? So I'll be taking a class on swellings. We will discuss swellings are invariably the short cases in surgery. Any case in surgery is a swelling. It may be hernia, varicose, anything. It's a swelling, or it may be ulcer. Only 2 types of cases are in the surgery. So tomorrow we'll discuss about all the short cases in surgery, about swellings, like a case challenge. I'll ask you some pictures. I'll show you some cases, and you will answer. We'll have an interactive session tomorrow. Please join us for the case challenge about swellings tomorrow. Thank you so much. Thank you, Shravan, for your wonderful work, and thank you, Nishanth and Kaustubh.